All right, so ready to begin now. So good evening, everyone. And okay, so the first session on our runner-up to World Antibiotic Awareness Week. The first session is on understanding CLSI, the very, very basic of antimicrobial sensitivity testing, as we all understand. But very often I've heard from PGs that they get confused, particularly with the newer versions which have come in 2024 and 23, where they've changed a few things instead of some nomenclature, some drugs. So this is going to be a general document revision for you. And tomorrow I will talking about the focus on gram negative. So it will be an extension of this lecture only. What CLSI says, some part will be covered today and the rest will be covered tomorrow. For gram-positive organisms, Dr. Sumit would be taking a session on VRE. Again, this was a particular thing which got left out last time when he took for GPCs because of paucity of time. And the last one will be your revision on antimicrobial stewardship as to if you get a question, how and what to approach. So without wasting any time, we'll delve into this. This is something which you are very familiar with. Any lab CLSI documents that we use for AST, the most common document that we use is actually M100. And M100 is not a full document. It is an addendum to actually M02 and M07. M02 actually gives you a document for disk diffusion. It tells you what should be the media, what should be the depth, what should be the pH, what should be the composition, how the disk should be prepared, and everything. Then the 07 documents talks about the dilution testing or the MIC testing, and the M100 are actually a table that if you do these distribution or these MIC, how you should interpret the results of M02 and M07. So A stands for the document which is approved every time we have this on and just give me a second. I don't know why this meeting is not getting recorded today. So it says it's being recorded. While the S document tells you the supplemental documents. So these two things will be there whenever we are talking about any of the documents which are, um, you know, um, so if you have an M134S, then it is a 2024 document which is released in 2024. If it is 33, then it was 23. Now, M02 and M07 are actually revised only once in 3 years, whereas M100 is updated every year. So there is a CLSI subcommittee which sits on this and which does all these revisions, and it comes to some conclusion, and these M100s are the tables which get revised. So sometimes you might be surprised that there will be a subtle change in the distribution diameters as it happened in 2023 with aminoglycosides or with Pseudomonas or with Acinetobacter. These are evolving things. Some drugs may get FDA approval, so they are added every year to M100. And the first few pages of the document actually allow you to see these changes if you are familiar with the original version. So, in what changed in 2024 document? Actually, in 2023 itself, it changed to a tier system in order to encourage cascade reporting as part of antimicrobial stewardship activities. And it also gave specific breakpoint tables for Salmonella Shigella. Earlier, it was only mentioned with enterobacterials that it is for Salmonella and Shigella, this drug is not to be recommended, or this drug is actually recommended only for Salmonella typhi. Now they have a separate table. Then there are certain breakpoint deletions for Stenotrophomonas, and there are some breakpoint changes for Linezolid and Staph aureus, one of the very common things, minocycline for Stenotrophomonas, and they introduced the broth disc dilution method for ceftazidime, avibactam, and aztreonam. And they also added Acinetobacter to the direct sensitivity testing from blood culture in addition to the enterobacterials and Pseudomonas that they had. So I've tried to cover most of these in this But first, what are the basics and what gets asked in the Viva most often is what is a breakpoint? Breakpoint is exclusively used actually as a clinical breakpoint. We may call it a breakpoint, but it's actually a clinical breakpoint that we are talking about. In that breakpoint, you will have a susceptible category that if it is susceptible, consider it an 80-20 rule. If it says susceptible, then 80% of the time the patient is likely to respond to this treatment. And at these concentrations, always remember these breakpoints have taken the PKPD into considerations, and as a result, these breakpoints will have the organisms as you know responding at a particular dosage in a particular duration. If it is BD, or if it is TDS, or if it is once a day, it will respond to that. Now, the organism is categorized as susceptible, dose dependent, intermediate, resistant, and non susceptibles. And there are minor differences in all these categories. And these actually take into consideration the in vitro, in vivo data for PKPD, the pharmacodynamic and the pharmacoclinical parameters, and that is why they are also known as the clinical breakpoints. So, all the clinical outcome data may not be available for every drug. So, if a drug is new or still in the trial phase, there will be an asterisk which will mention that complete clinical data is not available. For example, for Salmonella typhi, you will find it says minimum clinical data available. So, if you have a ceftriaxone resistant Salmonella typhi, the table very clearly says that if you're using one of the carbapenems, remember that very minimum clinical data is available. So, the MICs or the zone diameter values which are generated by the susceptibility test can then be interpreted. So, of course, susceptible is 80% of the time it should respond. Although the definition does not mention 80%, it actually means. The definition simply mentions that it is likely to respond to this treatment at this particular concentration. Similarly, susceptibility, which is dose dependent. Certain drugs you can increase the dose. You can go from twice a day to thrice a day, as you have seen with which drug? Please put it in the chat box. Which drug you think was the first to be given by CLSI in the SDD category? Then an intermediate category. Very often the clinician gets confused in intermediate, although there is a lot of clarity for the microbiologist on this aspect, but very often it is the clinician who gets confused. It is a kind of a buffer zone which is given to the clinician, but it actually means that either the place where the drugs get concentrated, that area, so, or at an area where you can increase the dose, intermediate will work. So, susceptibility, inhibited. Resistant is which is not inhibited by the achievable concentrations of the agent with normal dosage schedule. And intermediate is that the the MIC is approaching that of the resistance but is not fully falling into the resistance zone. For example, any zone diameter which is bigger than 20 is considered susceptible and less than 15 is considered resistant. So between 15 and 30, the agent can be used, but with what conditions? Either it is safe enough that you can increase the dose, maybe you can go from 100 gram OD to 100 gram BT, or like azithromycin, you can go from a 500 once a day to 500 twice a day sometimes, like you do in enteric fever. Or the agent may be efficacious. That is, if it gets concentrated. Like it's, say, example, it is a urinary antibiotic. It will get concentrated in urine. It will achieve a much higher dosage or concentration in the urine than what is required to kill. So, in these situations, you can give this drug. Or if, say, in CSF, the drug gets highly concentrated, CSF is a very tight zone in the body. So, these are the areas where it can be given. And technically, it is a buffer zone, which, prevents strains from a borderline susceptibility from incorrectly. Sometimes you land up with a situation that you have only two are intermediate and the rest are all resistance, and you want to give some option to the clinician saying that okay, you can use this drug. Now, dose dependent, has anybody answered as to what we get when it is? No, it's not piptaz. It is not piptaz. So it is actually It is actually cefepime, against which the first dose susceptibility parameters were given. So as you can see here, if we talk of SDD, we say that the MIC would be 4. If you give a dose of 1 gram for every 8 hours, that means you're giving 3 grams in a day. Or MIC will be 8 if you're giving 2 grams every 8 hours. That means almost double. So this is an area where this is being correlated with this, and for the lower dosage, the zone diameters are not available because it was not possible for them to highlight this. Now, this was introduced in 2014. Now, for many drugs, you have SDD. If you look at the table, as the data keeps coming in, they keep adding the SDDs. So they added ceftorelines for Staph aureus or MRSA particularly. They added daptomycin. They added piperacillin tazobactam in 2022. Then you have something which is known as the epidemiological cutoffs. Now, the epidemiological cutoff concept came from UCAST. It did not come from CLSI, it came initially from UCAST. Now, technically, ECOFs are not, or epidemiological cutoff values, or ECVs as the CLSI calls it and the UCAST calls it ECOF. Now, these two are actually, just like America and Europe, they are at loggerheads with each other, but they actually give the same thing. So there might be certain changes in the UCAST this thing, but what UCAST gives is ECOF for certain drugs. ECOF simply means that it is divided into a wild type and a non-wild type. Wild type is something which is present in the environment and has not mutated, has no resistant marker. Whereas the non-wild type means that has certain resistance markers. It has certain genes. It has developed its efflux very fast so that it throws the drug out. Whatever mechanism they have developed, it is labeled as a non-wild type. And this non-wild type is labeled as an NWT. So ECOF can only divide between the non-wild type and the wild type. It does not take into consideration the PKPD parameters or the clinical parameters, so they cannot be used as a clinical parameter. Can we replace intermediate with SDD? Yes, you can, but maybe only when you have that much of data for all the drugs that it can be replaced with SDD. It's very good tool for implementing antimicrobial stewardship. Again, non-susceptible. Non-susceptible is where there is no interpretive criteria which is available. That means you've never encountered a resistant pathogen. Where will you see this kind of a situation, that you've not encountered a resistant pathogen, and as a result you do not have a resistant breakpoint? Anybody? Which organism to which drug are we talking about? So if you encounter that resistant, you call it non-susceptible. It's not responding. I don't know whether it is resistant or not, but it is not sensitive as per my lab data. Any drug bug combination that comes to your mind when we see this? Now, how do you use M100 in the lab? What are the parameters that you use in this? As pneumotopenicillin, I think we've encountered to a certain extent. Anything else? Yes, strep pyogenes to penicillin, cornybacterium diphtheria to penicillin. These are not yet encountered. So these are the drugs which, if you find them, you call them non-susceptible. Now, how do you use these tables? Don't get confused by the bulky document. Very often I have seen PGs taking a printout of the thick CLSI and carrying them with themselves in the whole department. Especially they do that in my department. They think that, oh, it is getting imbibed by passive transmission to a certain extent. So you need to know only those things which are going to be effective in this thing. So if you are short of time and you have less, read your CLSI only for those organisms which are going to come in your exam. But if you are beyond PG, then maybe you should read for anaerobes, for Haemophilus, for meningo, for other organisms also, because you will need these information when you're routinely testing. So the table 1 and 1B give you routine testing and reporting. 2A to 2L tell you criteria for these interpretation, including their QC strains. Then the remaining 3 table, various types, tells you how to detect ESBL, how to do colistin, agar dilution, so on and so forth. And then you have anaerobes and you have some other information which is listed. This slide is older one, so maybe we've had a few more tables now in the newer ones. Now, what is a tier reporting, which came in 2023 and has now gone up, is become a norm with 2024 CLSI, is in tier 1, you have what you earlier used to call the routine primary testing and reporting. So those of you who are before 2023, you will remember that the CLSI used to tell you table 1A, this is routine reporting, a box used to be there, this is urine reporting, this is special case reporting. Now we label it as a routine. So here you will test for all routine and you will report all routine. Then you have a tier 2. Tier 2 means a reporting which follows cascade. So you can make your own institutional law or your lab laws which tell you that what is tier 2. Tier 2, you do testing for all routine and you do cascade reporting when you're giving your report. You do not do it for all the drugs. Tier 3 is when you have a high risk for multi-drug resistant organisms. So again, you report it as per cascade rule. Suppose you are a tertiary care center, you get patients who are very sick, ICU patients, or you get patients who've already been on certain antibiotics and you feel would have become resistant. Then you test as routine and you may also do certain drugs by request. And you report again as cascade. Then tier 4 is that when 1, 2, 3 cannot be used or reported. Suppose there is a kidney failure patient or a liver failure patient, and the clinician says that, see, these are the drugs to which you are saying is sensitive, is not going to work in my patient. It's a child where you can't report fluoroquinolone, trimethoprim, sulfamethoxazole, and then you feel that, okay, then we will have to go for tier 4. The reporting here and testing both are by request, or you may take your own call if you find that none of these are working or are useless in tier 1, 2, and 3. One rule, whatever rule you make in your institution for cascade reporting, remember that if you get a sensitivity to tier 1, usually we do not report tier 2. That is the usual rule. If there is a sensitivity to tier 2, you do not report tier 3. And tier 4 is anyway by request. This is the usual institutional request, but you can have your own request. For example, you have a dialysis patients and you routinely report in tier 3 something which is nephrotoxic. So you might have to change or tweak a little bit that, okay, we have kidney patients here who will not be able to benefit with this drug. So I'm going to add a few more drugs here. Always remember that if you have a broader spectrum agent to which it is resistant, it should always be reported even if you get a sensitivity to narrow spectrum. Means that if you have a resistant to a tier 2 antibiotic, but tier 1 is sensitive, you will always report that resistance, because what might happen is that if your gentamicin, I am just giving you an example, if for example gentamicin is sensitive but amikacin is resistant, it usually doesn't happen with aminoglycosides, but a hypothetical situation. If that happens, always report that it is resistant to amikacin even though it is sensitive to gentamicin, because they might believe that jenta ko sensitive hai to amica ko bhi hoga, and the patient might land up in a clinical failure. If you have any queries in between, please keep typing in your chat box so that you don't miss it at the, just don't wait for the end, keep typing. I will either answer, take them in between or at the end. Now there are certain sample restrictions which are there when you're looking at cascade reporting. Cascade reporting simply does not depend on the fact that what works in tier 2 and what works in tier 3. So if you have an abscess where you are likely to encounter anaerobic or mixed organisms, you do not report aminoglycosides. If you have an isolate which has come from lungs, you do not report daptomycin. Why? Why don't you report daptomycin? Anybody is my EGPGs? You are quite familiar with this question of mine. Blood, you don't report tigecycline. Again, why? Urine, you don't report macrolides, clindamycin, minocycline, chloramphenicol, and tigecycline. Whereas in CSF, you don't report any of these. Oral agents, you don't report first and second generation cephalosporin and cefamycins. You don't report doripenem, ertapenem, meropenem. The only carbapenem you report here is meropenem. And you don't report clindamycin, macrolide, tetracycline, and fluoroquinolone. Why? Okay, so we do have certain answers. Yes. Yes, Shali, the daptomycin gets inhibited by lung surfactant, and that is why you don't reply it, you don't do it, and you don't send it. Even when you have a bowel fluid which is coming sensitive, you don't do it. Most of you are able to answer surfactant. Good. The concentration of tigecycline in blood is very, very low. So you don't give tigecycline. Then these antibiotics don't get concentrated in urine, so you don't go give. And again, these will not cross the blood-brain barrier, so you will not report. Because अगर आपने गलती से कर दिया और उनको actually clinicians remember this, that these are not going to cross the blood-brain barrier, but we don't want to take that risk. They'll put it on us that you reported it, so we gave it. Then there are certain situation-based restrictions. For example, in children, you don't report fluoroquinolones, tetracycline, cotrimoxazole, and chloramphenicol. You all know that chloramphenicol causes gray baby syndrome. Fluoroquinolone is inhibitory for their epiphyseal plates. Tetracycline and cotrimoxazole are again not given to children. Similarly, for pregnancy, they might end up with teeth deformity and things like that. So you don't give these metronidazole, fluoroquinolones, and other drugs in pregnancy. Now, again, these are certain drugs which will be active in vitro, but should not be reported or must not be reported in your reports. For example, first and second generation cephalosporin, cefamycin, and aminoglycosides for Salmonella and Shigella. In MRSA, the moment you get it resistant to cefoxitin or whatever method you're using, remember that except for those which have an anti-MRSA activity, the fifth generation ones, you don't report any of these beta lactams. Enterococcus, don't report aminoglycosides except if there is a high level gentamicin resistance or if you form, because alone aminoglycosides are not going to work. Similarly, cephalosporins, clindamycins, cotrimoxazole, they usually appear to be sensitive in vitro, don't report. And of course, isolates from CSF, we've already discussed. Again, fecal, what do you report then? If you have a fecal Salmonella and Shigella, report only 3 antibiotics. And this is one of my favorite questions in MD exam. If you get Salmonella and Shigella from stool, what will you report? If you get it from blood, what will you report? You will report ampicillin, cotrimoxazole, and fluoroquinolones. So ACF, always remember it is fecal, it is F. Salmonella has an A, so you think of A, and a C is another one which you can add. So ACF, you report for fecal Salmonella and Shigella. If it is an extra-intestinal Salmonella, you add a third generation cephalosporin to the above, and you can also add chloramphenicol and azithromycin upon request. Remember the third generation cephalosporin is your ceftriaxone or cefixime. Now you can report these because these drugs will not have a very good concentration in the blood. Azithromycin, because it has a long shelf life intracellularly, but it is a bacteriostatic drug, so it's not going to work by itself. So you have to add it to another cephalosporin. If you have seen, none of the physicians will give you azithromycin alone if they give you standard diagnosis of typhoid. So they are always looking for third generation cephalosporin and azithromycin, and third generation cephalosporin resistance is actually creeping. Again, azithromycin, remember, report only for Salmonella typhi. It does not work in paratyphi. Now, non-typhoidal Salmonella from intestinal source, AST is not recommended. And Shigella and typhoidal Salmonella, either it is extra-intestinal or intestinal, AST is always recommended. For NTS, it is not recommended. It is from intestinal source. Now, there are certain tests which are given in your CLSI. Some of them mention that this is a routine test, some are supplemental tests, some are screening tests, surrogate test, and equivalent agent test. And very often, children get confused whenever we ask them. Routine test is actually based on the clinical efficacy. For example, we said azithromycin works for Salmonella typhi, not for para A and para B. Prevalence of resistance. If my isolates are 80% or 90% resistant to ampicillin, I may not want to report ampicillin at all in my testing or in my forms. If there is minimizing the emergence of resistance, that is the whole fundamental behind resistance, that we minimize the emergence of resistance. and depending on the regulatory approval. The regulatory approvals are actually required because uh, if you're using something which does not have a regulatory approval, then you are not actually benefiting the patient. I will give you one example. There is a drug which is a cephalosporin along with EDTA, which the company guys keep coming to you and ask you to report its sensitivity and resistance. But this is not approved by FDA or by the CDSCO or our own body. And then there are no breakpoints which are available. And they will tell you these are our breakpoints, but those breakpoints are neither CLSI, neither in UCAS, so then they become a problem. Then current consensus is also very important. Maybe your along with your hospital, what comes in your formulary or what you may not end up by giving meropenem to everybody just because it is coming free in the formulary. So you have to have a consensus with your clinicians before deciding on your routine clinical panel. So my advice to you is make a panel and send it to them and ask their feedback that see this is what we report for E. coli, this is what we report for Klebsiella. And those laboratories which are actually in surveillance might be having testing other drugs which are required for surveillance practice. So may not be important to report it. And of course, lastly, the cost. And it depends actually on your center also. If you're a tertiary care center like we are at MAMC, where we have a high volume center, it may not be very feasible to hold back the tier 2 and tier 3 because our patients have already taken antibiotics or they are very sick. So in that cases you may want to prescribe everything, test everything to save a day. Now what is an equivalent agent? Equivalent agent is when you test for A and predict the sensitivity of B for the same. So it either A or B can be used for a treatment. So you test for A but you say that B is sensitive. Surrogate is when you use one agent and one of the agents of the same class, but the other class is prescribed. It may or may not be used for treatment. The example here is pfloxacin or cefoxitin for MRSA. You use cefoxitin to detect MRSA, but you do not say use cefoxitin for treatment to such an extent. Similarly, pfloxacin you use to predict sensitivity to ciprofloxacin, but it may not be used for treatment. So there may be a performance issue. For example, if you want to test for methicillin resistant staph aureus, you will have to put salt in the media, decrease the temperature of your incubator. So all those you want to avoid, you are testing by using a cefoxitin. So if the surrogate performs better, as happens with pfloxacin, it's easier, the performance issues are not there. In those cases, you will use a surrogate agents. So, and then what are equivalent agents? Equivalent agents is I can test for cefoxitin or ceftriaxone for enterobacterials. Both of them will work. For Pseudomonas acinato, and I can test either for colistin or polymyxin, both of them will work. Similarly, for staph, now it works very well for macrolides, azithro, clarithro, erythro. Any you check, it is one and the same. Cipro and levo. Remember, it is not cipro and norflox as it is in our common minds. It is cipro or levofloxacin. So I'm not going to touch the additional ones. Then, what are the various predictors or surrogate markers? If an enterococci which is susceptible to penicillin only sensitive results, then I presume that it will be sensitive to these also, only sensitive. If it is resistant to penicillin, then I can't say that it is resistant to all of these because it might be sensitive to amoxicillin clavulanate if it is a beta lactam mediated resistance. If it is a beta lactamase resistance, I've added a beta lactam inhibitor. So in enterococci, which are sensitive to penicillin, it will remain sensitive to all these. But a resistant to penicillin will not be resistant to these. It may be resistant to ampy, amoxi, ampicillin, but not to ampicillin amoxi. So that I have to report separately. Now, enterococci that are susceptible to ampicillin or are even resistant to ampicillin, it will be resistant to all these, even to imipenem for E. faecalis only. Tetracycline only sensitive results will be susceptible to doxycycline and minocycline. Again, very interesting analogy for any drug bug combination that you're using. If you're using tetracycline for that bug, if it is sensitive to tetracycline, it is sensitive also to doxy and minocycline. But if it is is resistant to tetracycline, then it is not compulsory that it will be resistant also to doxy and minnows. That you have to test separately. Streptococcus pneumoniae to levofloxacin, if it is sensitive, it is also sensitive to moxifloxacin. Ampicillin for enterobacterials, both, as I said earlier, it will be resistant and sensitive to moxi as well. Beta-lactam only sensitive, then of course it will be sensitive to one of the inhibitors as well, but not resistant. Now, when you look at surrogate, the most common surrogate that I also referred to was cefoxitin and pfloxacin. Cefazolin, sensitive results only. Cefazolin predicts for all oral cephalosporin first and second generation, which can be used for uncomplicated UTI. Actually makes things very, very easier. But cefazolin is not used for treatment, but any of these drugs can be used for treatment. Similarly, oxacillin for pneumo and nalidixic acid for salmonella predict susceptibility to fluoroquinolones. Now, with the high development of NARST, nalidixic acid resistant salmonella typhi, this has become a little difficult, but it's still there. Then what are the supplemental tests? Supplemental test is that you have to do in addition to doing a sensitivity. Say, for example, staph aureus, you are doing a sensitivity to macrolides and you're also doing a sensitivity to clindamycin. Now, do you do an inducible clindamycin resistance or ICR when you look at staph species? Yes, you do, because isolates that test resistance to erythromycin and clinda susceptible, you can't report them if they are D-test, only if they are D-test negative. Otherwise, they will develop resistance the moment these drugs are given. Beta lactamase, of course, if you are looking for penicillin, this is actually gone for Indian scenario because we usually don't get any sensitivity to beta lactam drugs. Again, ESBL are again optional. I'll be coming to that when I discuss about GNBs as to why ESBL and carba-NP are, you know, done. We'll come to these. Then MSIM without this we'll do tomorrow. This is something which is in bold, is added new this year. Astronam plus ceftazidime avibactam broth dilution. All these which are lighter in color were there earlier also, but now these are added. So there are certain supplemental tests which you have to do in order to determine whether the isolates are susceptible or not. For example, if you do colistin MIC, you have to do a modified agar test. You can do a broth elution test if you are doing this. And an oxygen salt agar if you are looking for a non-MEK type of resistance. Now, what are the various screening tests? Screening test is that it provides a presumptive report and it gives you an additional testing by confirmation of resistance. So you can use a vancomycin screen agar, you can use high level aminoglycoside resistance by diffusion. Later on, go for a broth dilution or a broth dilution MIC. In agar dilution, always remember that you will miss certain isolates when you use vancomycin agar screen. You can use for GPCs like staph and intro. And anybody would like to answer this as to why are we going to miss certain isolates if we use only vancomycin screen agar, we do not use agar del. So every time we are using a screen agar, we have to confirm it with MIC for that reason. Anybody can think of it why this is happening? Why, if it is screen positive or whether it is screen inconclusive, then only you do it for high level aminoglycoside. But if it is screen is positive, vancomycin is a very heavy molecule. It doesn't move that easily in agar. So this you have to do you have to test it by confirmation. So why this is MIC is below can be missed. Yes, Kevin, very right. What actually happens is that this you're testing at a 6 micrograms per ml. So only the strains which are uh, capable of growing at 6. But then what is the MIC for vancomycin? And then you will have a complete answer. Your answer is partially right. So remember that ESBL and carbapenem screening is recommended to enterobacterials if the current guidelines are followed. You do not do it for enterobacterials if you are following post 210, which all of us are. And then always remember intrinsic resistance. We'll come to that. And what are the intrinsic resistance? Now, remember that certain drugs cannot just enter. I cannot go into somebody's house if nobody opens the gate for me. Similarly, in intrinsic resistance, certain drugs cannot enter the outer membrane or the lipopolysaccharide in the gram-negative bacteria. And the favorite of the organism to have intrinsic resistance to a host of drugs is Pseudomonas aeruginosa and to a certain extent the Proteus providentia group. Or their natural activity of efflux pump is so high that the moment the drug enters, it gets thrown out. दरवाजा खुल भी गया तो I will be shown the door कि अब we don't need you, please get out. So if either the drug is not able to enter, if it enters, it gets thrown out. The issue here is that for anaerobes, that is why I said initially, don't report aminoglycosides for anaerobes because they are intrinsically resistant. Many of the beta lactams, quinolones, all gram-positive organisms are resistant to astronams, to colistin, to polymyxin B, enterococci, to a host of drugs. One troublesome organism. Listeria monocytogenes to cephalosporins, all gram negatives to all glycopeptides, lipopeptide, digicycline, vancomycin, E. coli to all macrolides. This gets slipped out. Only macrolide which works for GNB is azithromycin and it works for, always remember, azithromycin is for atypical. So the atypical enterobacterials is Salmonella Shigella and the atypical organisms, you all know what they are. So azithromycin works only for atypical organisms. Klebsiella, ampicillin, again, one of the biggest mistake that you do in AST lab is reporting Klebsiella for ampicillin. Serratia marcescens for colistin, ampicillin, amoxiclav. Sood, you all know, host of drugs. Cynotrophomonas maltophilia, again a host of drugs. Acinetobacter, again for ampicillin, cotrimoxazole, fosfomycin, ertapenem, astronam, and so on and so forth. Somebody is asked what is tier 1 is actually what we used to call as the first line reporting. Yes, tier 1 is actually similar to that, what we used to call a routine reporting in CLSI. So what these tables I will just rush through because these you can always remember. You can click a photo if you want. Tier 1 is a simplified version from your CLSI. Ampicillin, cefazolin, ceftriaxone, amoxiclav. Now remember, the only trick here is the urine drugs are there either in tier 1 or in tier 3. There is no tier 2. So you have cefazolin, which means all first and second generation cephalosporin, and nitrofurantoin, of course, it is a urinary antibiotic. Salmonella, Shigella, this we've already discussed. These are the drugs that you can report in tier 1. Remember, ceftriaxone is getting repeated in tier 1 for Salmonella. Tier 2, of course, a little higher and all the carbapenems here. Then, of course, aminoglycosides have got a cascade mechanism. So, if Genta was here, amikacin is here. And again, tetracycline because it's a more rarely you find resistant strains. So, nowadays, because of less usage. Then, for Salmonella and Shigella, it is azithromycin for typhi and Shigella species only. For tier 3, again, the higher ones, the ones which are, still being held upon. These are carbapenem and inhibitors and cefiderocol and ceftazidime avibacter. And for urine, fosfomycin, E. coli only. Tier 4 is astronam, all these again, which are, which have got certain inhibitors, beta-lactam inhibitors attached to it. And as I said, for Salmonella and Shigella, all these have got a limited clinical data, so they are not going to tell you as to what it is. This we've already covered, so I had actually hidden this slide. Again, for Pseudomonas, ceftazidime, cefepime, piptaz, tobramycin, ciprofloxacin, and levofloxacin. And in Acinetobacter, again, ampicillin, ceftazidime, these are all tier 1. Tier 2, carbapenems, tier 2 carbapenems, and amikacin. Tier 3, again, similar kind of a drug, which we did for that. Remember, for Acinetobacter, doxycycline, colistin also come into picture. Now, certain unusual organisms which we often encounter nowadays that we rely more on automation and less on your regular machinery of TSI and catalase and coagulase and things like that. We all have become automation heavy, relying on Vitek and Maldi, and we get often Burkholderia, Stenotrophomonas, or other non-enterobacterials. Now, one of the tricky thing here is the Stenotrophomonas and Burkholderia cepacia complex both respond very well to minocycline. So always remember to it as a go-to drug when you have this. And this you can predict from tetracycline if it is sensitive. If you're not tested for minocycline, don't worry. If it is sensitive, you have no issue. Again, ceftazidime, meropenem, cotrimoxazole, all this can be there. Staph, of course, any of the macrolides, clindamycin, of course, after you've done your ICR or inducible clinda resistance. Cefoxidin or oxacillin, whatever you're doing, it will be in the first. Again, tetra, mino, and doxy in first. And remember, tier 1 is vancomycin because 60 to 70% of the isolates all over the world, as per GLASS report, are MRSA. So if you have MRSA, you have to give a tier 1 drug to MRSA. So that is why vancomycin is here in tier 1. So this is again a question, why vancomycin being such a reserved drug is being kept in tier 1 is because the treatment of MRSA is dependent on this. If you see here for enterococcus, it is not there. It is a combination of AMPI and PENI, and in the second tier you have vancomycin. It is all with Genta. High, it's not there. Then again, linezolid is tier 2, and the newer one, tedizolid and ceftaroline or lefamulin or rifampicin is in tier 3. Dalbavancin or ritavancin, telavancin is again comes into tier 4. Many of these are not yet even available in India. So only MIC testing is recommended for which organisms? One, if you get a vancomycin screen positive, then you have to confirm with MIC because there is no zone size, which is, as I said, it's a heavy molecule. Streptococcus pneumoniae, the results are very unreliable with penicillin, cephalosporin, and carbapenems for this diffusion. So you always do MIC. Acinetobacter, Enterobacter you for colistin or polymyxin, and for tigecycline. Tigecycline, remember the breakpoints are only given by FDA. They're not yet given by CLSI, but the clinicians often use and they ask you for this. So if you look at staph, the routine testing of the staph isolates, remember this, cefoxidin works here. This is the question that I was asking, that why don't we, is there a need to do an oxacillin diffusion? No, because most of the coagulase negative staph also would be okay with a cefoxidin diffusion. Most of these are a staph epidermidis or lugdunensis will work for this. And anything which is 96% of the strains are usually MEC-A. So MEC-A can be picked up very, very well by your cefoxidin test. So other than MEC-A, if you have a novel MEC-C, then they are typically cefoxidin resistant and oxacillin susceptible. Another viva question, that if a strain has got any resistant mechanism other than MEC-A, what will be detected? They are typically cefoxidin resistant, but they are oxacillin susceptible. So for these drugs, you will do both. You will do cefoxidin as well as oxacillin, but they are very, very less. MEC-C will not be detected by tests which are directed at MEC-A or at the penicillin binding proteins 2A. So remember that if you are testing vancomycin for enterococci, you have to hold the plate for 24 hours. Sorry, the hours got missing here. Examine zone using a transmitted light. What is a transmitted light and what is a reflected light? So when you keep your plate like this, then it is a transmitted light. But when you read the plate like this, then it is actually a reflected light. So always you read it using a transmitted light, which is not seen with the other drug bug combinations. Any haze within the zone of inhibition indicates resistance, as someone rightly wrote in the chat box that it is the heteroresistance which is causing a lot of problem. A single bacterial population, progeny from a single colony, it will show you different types of resistance. The H visa. Intermediate by MIC methods always, and for isolates for which vancomycin MICs are between 8 to 16, you perform biochemical and rule out any intrinsic VAN-C type of resistance which is there. So whether you are working for staph or you're working for enterococcus, remember in staph you don't do any diffusion at all for vancomycin because the reasons are similar. But in enterococcus, you can do it to a certain extent after holding the plate for 24 hours. Now in vancomycin agar, we are taking susceptible at less than 2, intermediate at 4 to 8, and resistant at 16. So remember, our vanco agar is 6. So it falls somewhere in between. So you are likely to miss those between 4 and 6. So that is why I said it will not detect any of the intermediate strains. And some strains for which vancomycin resistance are 4 will also fail to grow on this because you've given a higher 6. Now, coming on to direct diffusion from blood, this is standardized, and 2 years back, CLSI had introduced it for enterobacterials, and then it introduced it for Pseudomonas and Acinetobacter. But remember, enterobacterials for Astronom, ceftazidime, tobramycin, and ciprofloxacin does not apply to Salmonella and Shigella. It applies to the rest. As I said, they are somewhat different than the other enterobacterials. For Pseudomonas, for these drugs, meropenem, ceftazidime, cefepime, tobra. These are all standardized. And this year, Acinetobacter has also got added for direct sensitivity. So with that, I will stop for today's this thing. And if you have any queries, please post it up in the chat box. I can take it up, or if I will just stop share, and if we have any questions, we can take it up, or if you want, okay, one dilution check. Explain SDD again. See, SDD is when we are giving actually two types of, you know, the parameters are double. In the one, you have sensitivity zone or resistance zones for a drug which is being given at a particular dose. For example, cefepime, if it is given at 1 grams BD, then the zone breakpoint is 4. But if it is given at 2, then it is 8. So that is the reason why, if you have to ask the clinician what dose is he prescribing, or you report both, that if they want to increase the dose, then this is sensitive or resistant as per your. So when you're determining your sensitivity or resistance as per the dose which is being given, it is SDD. Otherwise, it is similar to an intermediate type. What are the reasons we have to say not testing vanco or staph aureus by diffusion? See, first reason is that vancomycin is a huge molecule, so it doesn't move. When you apply sensitivity, you usually give about 16 to 18 hours for the plates to read, and that is what CLSI also mentions, that in ambient air, the plate should be incubated for 16 to 18 hours. They are common for all the tables. It is mentioned in those boxes where the document starts for each. So if you have uh, something which is the drug is so heavy that it's not going to give you a proper zone, then you cannot rely upon it. So that is one of the main reason why we don't do vancomycin sensitivity. But for enterococci, it works because the drug, you are keeping the plate for 24 hours, and enterococcus compared to staph is a slow growing organism. See, when you test the diffusion parameters, you have to remember that both these things have to go in a very synergistic manner. The way the drug is diffusing and the way the organism is growing, so that at a point where they inhibit each other, you get a zone of inhibition. Now, if the organism is going like this and the drug is moving like this, then you will not have a proper zone of inhibition. So if the organism is moving slow and the drug is also moving slow, you allow it more time to diffuse so that they come to a same point. That is all about uh, the vancomycin. Okay, thank you everyone for the comments. Anything else anybody wants to ask related to MIC? Tier 1 equivalent to first line drugs? Yes, it depends on your, although you can make your own cascade reporting rules, you can include all tier 1, and you can have one or two of tier 2 if you think that you are a very high center which gets a lot of resistant pathogens, or your the resistance rates are very high. You can use one of the tier 2, you can use one of the tier 3, and it'll work. So anybody? Okay, I don't think there are. Penicillin susceptible for syphilis can. Syphilis, we do not test the sensitivity in the lab. Okay. Penicillin, we can say it's non-susceptible. Where are you testing the sensitivity? You're not testing. You're not isolating the organism and testing the sensitivity. The method for that will be totally different. It's not covered under this purview. Any other question, anybody? Calculate therapeutic index BMQ with AST. Again, another lecture. We'll cover it in that. Drug resistant index, therapeutic index. You divide your MIC with the breakpoint. And yes, it works well for ICU patients. And it's considered better than giving an MIC. We'll take it up in another session, maybe. All right. Anybody would like to say anything? Anybody from the executive committee is here, or I don't think Dr. Bharti could join today. Anybody would like to add anything? Or we'll log off for today and we'll meet you tomorrow again for the GNB portion. Please keep your queries ready. Thank you. I'll be ending the meeting.
Good evening, ji. Nice presentation, Dr. Dr. Sonal. Nice presentation. I think these are the Viva questions which you have explained today to all the PG residents.
Dr. Vinny, thank you. Hope the children could benefit. If your friends could not join, please tell them to watch it on the YouTube. It was streamed live, but they can also see it at their own time. All right. Thank you.